Okay, I'm wearing my company shirt, and I've decided to feature our company logo in the background. In case you can see, it's Heart and Soul Hospice. I don't know if you can see all of that, um, but that's what we have on our wall in the company office. Um, I started out as he said in the lab. I was grateful for that, and I was a med tech registered ASCP for at least 6 years, and I would have stayed in it except that Vietnam came from Uncle Sam said we need you more, we need you more in our army, so I had to go serve for about a couple of years. So that kind of got me out the lab, and then I applied to hospital administration, and Cornell accepted me, and so I went up there in uniform and said, "Look, I'm coming, but I don't have any money. Uncle Sam don't pay very much. I got $1,000 in the bank." And they said, "Okay," and they said, "We'll get back to you." And 2 weeks later, they gave me a full ride, so I got lucky. All right, so that's how I got into health administration, and as I was trying to explain and tell them some of my war stories, you guys, when I came along, hospitals still had animal labs, and we used to do pregnancy tests using rabbits and frogs. Okay, you guys just do the dipstick stuff now. We didn't have all of that back then. So anyway, I was a hospital administrator for most of my career. I've been the CEO of at least 3 or 4 hospitals, and Biomedical College was my longest tenure in Nashville. I was there for at least 15 years. So, and I enjoyed it. I ended up coming up to Detroit Medical Center, and I kind of retired from there. But during that process, I became interested in being an entrepreneur. Because I'm sure you may or may not want to be in administration at some point, but it's stressful. You make good money. Well, I didn't make any, but you make good money, and it's interesting. You got a lot of power. People talk to you. People call you, and I enjoyed it. But eventually, you kind of get nervous, and you say, "I'm going to have a backup plan." So my plan was either to own a lab or get into something else. And somebody talked me into getting into hospice. So this actually is my 8th hospice. I've owned 8 before this, 7 or 8 before this. And I ran them for a while, and then I sold them. I mean, that's the nature of business, okay? And so this one here, I really wasn't supposed to be involved in it, but 2 guys approached me, and they talked me into doing this about 3 years ago. And we got lucky. We got lucky and got approved just as COVID hit the country. How we managed to do that, I have no clue, but we did. And it was a little bit of a slow growth the first year, but this past year we've just been going gangbusters. We've got a branch out in Seattle. Somebody else out there talked us into doing that. It's too far from me. But and we're working on one in South Carolina, and another branch down in Memphis, and one in Charlotte, and one over in Tallahassee, Florida. Okay. But I won't be part of all of them because boyfriend needs to retire, and my wife is on me to travel the world. So I'm not going to be part of all of those. Okay. I'm going to help them get the one in Charlotte and Memphis, and then I'm going to tell them, buy me out. Okay. And I'm going to take that little bit of money, and then I'm running, I'm traveling. So that's the down and dirty of my career. But I urge you to consider both for-profit and nonprofit. And being an entrepreneur gives you a little bit of leverage. There's nothing like walking in there and everything in there belongs to you. Okay. And we've got about 75 patients, maybe about 45 or 50 employees. We've gotten so big. I used to know them all, but I don't know them all anymore. So anyway, that's my story. But I want to talk about hospice, and I'm pretty sure anybody here not familiar with hospice, you know what hospice is, though, right? Pretty much. Okay. I love cameras because everybody shakes heads and you know what's going on. I teach, by the way, for Purdue in Southern New Hampshire too. I'm cutting my teaching job back too. But I've enjoyed it. So anyway, I put this slide presentation together for you guys. Let me see. I got to be able to see you guys. So Can you see it okay? Are you able to see it without anybody not be, you
I
can't
don't
see it.
see
Oh,
the
oh, 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 I
PowerPoint
know,
yet.
I know, I know. I'm sorry.
Oh, you're
I
good.
forgot I forgot to do the share thing.
There we go.
How are we doing?
All right, we see it. Yeah, I think you just had to enter the
No, no.
presentation mode. There we
Yeah.
go.
Yeah, there you go. Is that better? Okay. All right. Here's what happened. We started it as a business venture, and then what happened is uh National Public Radio got wind of us and came and interviewed myself and my director of nursing. And uh, and then it just went kablooey. I mean, I don't know what happened. I didn't realize National Public Radio had that kind of reach. But as soon as they started publicizing it, we started getting calls from people from all over the country. There aren't that many minority-owned hospices in the country. There are about 4,500 of them altogether. But I've only been able to identify maybe 4 or 5 others. Okay, so that's all I've been able. But the publicity gave us that, and then we get calls from people, other hospitals that want to reach to the minority or the underserved population. So and we've got other publicity, other media entities have approached us, and so I said, okay, maybe we've started a revolution of change in hospice. So that's what this is all about. Okay. Like I said, we submitted what we thought was just a normal, standard, ordinary request, and lo and behold, they hadn't approved anybody in years, but they gave us our approval. So we said, okay, we're committed to serving the minorities and the underserved population, regardless of money and location. And to that extent, I will tell you, and I tell my staff all the time because they look at us as though we're rich. We're not rich, okay? We pay ourselves $400 a month each, and that's only for gas money. I tell them some of you all are making more money than I have, and I've been in this business. Okay, luckily I don't depend on it for a living. I mean, I teach and I got other things, but it's not for the money for us. Okay, so I'm just sharing things here. So I was thinking about what are we? We're not the Three Musketeers, but I think one of my partners is a bishop. And I said, and he didn't know a thing about hospice. We had to educate him. But we call ourselves the Three Mustard Seeds, the biblical reference, okay? So there's my partner, David Turner, who I helped get into the hospice business about 10 years ago. He and I co-owned a hospice early on, one of those that I mentioned. And Bishop Sandy, he didn't know a thing about it. We have to educate him. We still have to educate him. But we began to grow, and that's how we got started. And then now I was originally going to be a cartoonist. I wasn't even supposed to be in the health field. And I got offered a scholarship, and I decided, well, I was too nervous about it. So I'm going to go into something more steady. And so that's how I got into healthcare and decided to pursue that as a career. But I'm turning back to being to cartooning again as I'm nearing retirement. So I drew this picture to symbolize the three of us. Okay. So brief history, hospice, as you may or may not know, was started by this lady in 1963. And it was started overseas, but here I'm talking about here in this country. And then it kind of languished until the early 70s. And it was only when it was approved, it was founded in 74, still languished by 3 people, I think an administrator, a nurse, and another minister. It was called Hospice Inc. And eventually, when Congress approved it as a Medicare benefit, that's when it really exploded and began to grow like what you see today. Those 3 people, when they retired, I think they sold hospice, their company, for about 300 million, something like that. Chump change. So anyway, it's based on the following principles: comfort, dignity of life, quality of care for people who are transitioning. Okay, and just to let you all know, and I remind my students when I teach them, make every day count. Don't take any day for granted, because God did not promise that you're going to live to be my age. I'm lucky to be at this age. You may go tomorrow. None of you are going to escape death, so you better get used to it. Okay, And I always say, when you get up every day, focus, make sure that you accomplish something so that, because there's nothing worse in the world than to go to a funeral and somebody has to make up, well, she was a nice lady, everybody loved her. What did she do? Well, she didn't have a chance to do nothing, So I'm just trying to plant a little seed in you. Don't be afraid to talk about death, okay? Uh, I listen to, and I feel for my nurses because they deal with going to see people dying all the time, and I just don't know how they manage to handle that. Sometimes I worry about them, but they seem to be all right with it. Just so you also know, people who die transition mostly at night and mostly on the weekends. So I don't know what it is about dying. We don't seem to want to die Monday through Thursday, but Thursday through Sunday, oh my goodness, I hold my breath and say, okay, here we go. But anyway, some people die nice, some people don't. It's a struggle, But I always tell people also put your personal affairs in order. You don't want your family to struggle and argue over who's gonna get the dress, who's gonna get that necklace, who's she promised me the car, that type of stuff. You'd be surprised at what kind of stuff that brings on. But we do like to know that the people that are transitioning get the medical comfort. They don't suffer from pain or discomfort, and they get the care and attention that they want, because they don't always get it from some of the families. You know that, right? You can imagine. So most of the time, if hospice, Congress says you got to pass within 6 months or so, or less, and there are 4 periods to do that. I don't want to get into details, all of that sort of thing, but we have people that are, it's hard to predict when people are going to die. We have some that's been with us over a year, and I've had some that didn't make it but a few hours. Okay, so it's hard to predict. But a doctor has to make that declaration, and you can't have any efforts being made for restorative care. Okay, so I'm sharing with you some numbers. I apologize for that, but just in case you may not know, we deal a lot with Medicare enrollees, because Medicare obviously is the one that deals with most of the people that we're gonna deal with. And these are the numbers. I don't know if you can see some of those numbers and on the screen. You're not going to remember them anyway. Anyway, here's what the share of Medicare descendants who use hospice is up, as you can see, 51%. It hovers around 50% of the Medicare recipients. We're over 65, so we're the ones that are going to do this. So when I saw a movie the other day. I think it was called Burial, with Jamie Foxx in it, and the guy in that movie was he had a funeral service, and he said baby boomers. You've heard the term, the millennials and the baby boomers. He said the baby boomers are the golden age of death, because now they're coming of age where they're entering into this window right here, and so I'm expecting that these numbers will jump from 2021. I think they're going to go up even higher. Number of Medicare hospice users gives you some idea how that's been. And as you can see, it's been growing from 1.6 to 1.7, 1.7 here. As I say, I think it's going to grow even higher when we see the numbers for 22 and 23 and going forward. Number of Medicare recipients who use hospice by race. And this is our argument. 50% is white, and then the rest are broken down there as you see on the screen. But it falls off, and I think it's not. I think there's a cultural issue here with when you get into these different ethnic groups, as to how they perceive, their elderly, how they perceive how much involved the family should be used. There's a distrust in the some people of the medical industry anyway. They think that if they trust too much and put their lives in your hand, then they think you're going to be used and you die quicker. Some people think hospice practice euthanasia, which we do not, but they think that because we use a lot of medication to keep the pain and discomfort down, they think that in effect, I'm looking for a word here. Anyway, it almost makes a person comatose. But when you're dying, there's a transition stage, and they call it sundowner's disease. When you're in the last 4 or 5 days, a person who's dying may sometimes gets very active. Okay, and they start doing things and running around. You can't, and you have to keep up with them, or they'll go right out the front door. But that's when they're in that final stage, they get that way. So sometimes you do medication to slow them down to keep them from hurting themselves. Anyway, there's a distrust amongst ethnic groups, and I don't think some of the hospices reach out as much to different groups and some of the underserved populations like they should. Hospice, aside from hospitals, are the only entity in healthcare that cannot turn anybody away for financial reasons. That's written into the regulation. But that's not written into the regulation for home health, DME, home nursing homes, or anybody else. But it is in the regulation for hospice, and it is in the regulation for hospital. So, people don't know that we can't turn you away whether you got any money now. You present yourself to us and say, I want a hospice, you get it. You don't have to have Medicare or anything. You all are young. One of you all come. You're not obviously not Medicare recipients, but you can get hospice just by simply saying I want it. So anyway, there's some of the statistics in terms of length of stay. As you can see, I don't know if you may not be able to see these numbers. It depends on when the referrals take place. A lot of times doctors wait till the last minute before they refer a patient to hospice care. And the reason for that is they don't want to tell a family or a person, I've done all I can do. Okay, that's a very hard conversation for them. And I appreciate that and understand it too. But it means that in the meantime, they're burning up a lot of tests. They're trying to make the family believe we're doing all we can to save them. They put them in hospitals. They stay there too long. And so that when it's all said and done, the family gets whacked with a lot of bills that have been generated from all of this over testing and unnecessary stay in the hospital. And if you ask yourself, if you're honest with yourself, you have to ask yourself, where would you like to die? Okay. And most of us say, I want to die in my own bed in my own room, right? But half the people die in hospitals amongst strangers in a room and facility that they are not familiar with. So, and many times by yourself, because your family can't stay there till you decide to check out. So they leave. So you may end up transitioning when they're all gone. And that's so hospice says bring them home if the family can manage to accommodate them during this. It's a very trying time. So just something to think about. Average length of stay by location. Again, the blue is private residence, the green is nursing, and the orange is assisted facility. Okay. And that's the average length of stay but as you can see, most of them, and we get a lot of our patients from assisted livings facilities more so than anything else. Okay. Again, percentage point change of descendants who use hospice by race. Again, the whites are over here, the orange is Asian, black is down here at 0.1, green is Hispanic, and this down here is Native American. Okay, tax status. How many hospices? Well, wait a minute. Okay, there are 4,500 hospices in the country, and it's growing. When I first started, there were 3,500. Now it's 4,500. The vast majority are for-profit. Okay, it started out as a not-for-profit thing, but the federal government says it doesn't matter to them under Medicare whether you're for-profit or not-for-profit. They pay us all the same. Doesn't matter whether you started yesterday or you started 20 years ago. We all get paid the same rate. So if the rate changes, we still all get paid the same rate. Are you following me? Okay. So it doesn't matter what the status. We all are required to provide the same service, the same level of service. We have to have the same people. So hospice is one of the few places that is very clearly defined. what you are supposed to have and what you are supposed to do. So it doesn't really matter what your organizational structure is, whether you're for-profit or not-for-profit. A not-for-profit doesn't do anything any different than a for-profit does. You following still with me? Okay, now that may not be true for hospitals. It may not necessarily be true for home health agencies and other entities, but it is true for hospice. So how many were operating? As I said, oh, I told you 4,500. I beg to differ. I'm behind the times. It's up to 5,300 hospitals. You got to figure an average of about 50 or 60 hospices per state. That's about what you'll find, depending on the environment. Obviously, Wyoming and places where there's sparse population, they won't have this many. But the states that we normally think of have about 50, about 45 to 50 hospices per state. Okay. Oh, the difference is in some of these states is in Tennessee, you have to be approved by a certificate of need commission before you can even start a hospice. Whereas I've had hospices in New Orleans. I had one in Natchez, Mississippi, and I've had 2 or 3 in Michigan. And those states did not have certificate of need. You could just pretty much go ahead and, as long as you meet the regulation, you can go and get certified by Joint Commission or by CHAPS, and they will approve you, and that puts you into the Medicare program. But you can't do that in states that still have certificate of need laws. You have to get approved by them before you can start a hospice. And if you're wondering how much money does it take, my first hospice I did about 15 years ago, and I think cost me $20,000 to get it started. Okay. And I'm sure some of you all have that in your little piggy bank, right? I know that's no money. Look at Sydney smiling. She said, he's looking in my bank account. No. But now I will tell you, it cost us $200,000 to get the one we got going right now. Okay. So it's like everything else in healthcare, the costs have gone up. Okay. Now, if you ask me, of the 8 or 9 hospices I've had, where did I get all this money? Well, I paid for the first one out of pocket. Okay. I had one partner, and between the two of us, we put up the money. We had the struggle to get it going. And for 2 years, I think we averaged 2 patients a day. That's all we ever had. I mean, for 2 years, we didn't make any money. We didn't do anything. Then all of a sudden, HIV came along, and all of a sudden, we got flooded with patients because people were scared of HIV. So, and we were the only ones taking HIV patients. So that boosted us real quick. And we kept that. I kept that hospice for about, I guess it's been more than 15 years. Before I finally got, because I moved back to Detroit, so I sold my interest in it after about 15 years. The other hospices, I didn't have that long, 3 or 4 years, and it took increasingly more money to get them started. And so that, like I said, now you're up to 200. And if you're asking me, where did I get the money? Well, I'm glad you asked. And so I'll share a secret with you. Celestial, I'm going to share a secret with you guys, and you keep it to yourself, Paige. Yeah, I didn't use my money. I used other people's money. Okay. So I don't want you all to underestimate this. You're getting schooled at Michigan State. They're teaching you stuff that nobody else knows. So when you get out there and you decide to go into business, whatever business that might be, and I always say, don't do anything outside of healthcare because that's your expertise. People pay you for your expertise, and that's how you get the money. You know how to do what they don't know how to do. You're the mechanic of the automobile. Okay, we take a car to a mechanic because they know how to fix it. I don't know how to fix it, don't want to know how to fix it. Okay, but in hospice, I know how to do it. People pay me to do it. And so they put up the money, but I get, this is business. I'm talking business now. This is, and I get my piece, I get my share of the ownership. You understand? Okay. I'm not trying to, I don't want you to get pigeonholed and focused on just everything got to be nonprofit. It ain't none. That's not. But anyway, here you go. Characteristics of nonprofits. Here you go, right here. It just goes to show. See, it grew Nonprofits grew it from 3,600, grew 500 in 1 year. 1 year. Okay. I mean, for-profits. I'm sorry, for-profits. Nonprofits dropped a little bit. Okay. And then these are the other types of hospitals. Some are hospital based, some are home health based, and everybody's trying to get into it. So that gives you an idea of where some of the hospitals are located. Okay. Now, the key to any business, of course, is you got to keep your operating costs low, because remember, the payment is the same regardless of what the ownership is. So you still got to do that. So we always felt that nowhere in this whole landscape is diversity, equity, and equality thought of, and diversity has been slow to rise in the hospice industry. So there are very few minority-owned hospice CEOs. Not even talking ownership, but we couldn't identify more than 5 or 6 people in charge of 5,000 hospitals. There was only 5 or 6, maybe a dozen minorities at the top. Most of the minorities are spirituals advisors, and quite a few are in nurse and clinical roles, such as nurses and CNAs. Okay, this is a drawing of my nursing director. Relationships is what it's all about between the staff and the family, because hospice is about caring and spiritual comfort. So the better you do this, the higher the level of quick care. You got to remember, the patient is transitioning. Most of them pretty easily satisfied. It's the family that you got to deal with in the hospice business. Okay. And so we focus a lot on that. Okay. Older Black adults are less likely to report having documented wishes. We're finding this out. They don't trust people. They don't like to share things, and they keep their business. They're used to keeping their business to themselves. Okay, so I'm not going to get it. And this is some of my other staff. I'm mixing things up here. I hope you like my drawings. The secret is the team. You got to have a good team. Okay, this is my current director of nursing. The lady I showed you before, we made her the administrator. I was the administrator initially, but then I said, look, boyfriend, I don't want to be the administrator forever. I gave her a chance to get acclimated, so now she's the administrator, and this lady now is our director of nursing. Okay, but we take care of our staff. We put most of our money and our effort into it. I can't tell you how many gatherings, and we just took our staff out to a big game show venue here in Nashville, where they have all kinds of games. And they said, bring the family. They brought all the family, all the kids and everything. You know, had a great time. Okay. We keep a snack room, and we didn't start. Our folks like to snack. They're starting to, it's worse than going into a Walmart. They got snacks everywhere. And I don't say anything. And we have a team meeting. You got to have some food in there to snack on. I mean, I worry more about their health. I think we're making them fat or something, because they just love so much snacks. But anyway, we don't care. We said, let them have it. And we don't mind taking them out to dinner. We just gave away 10 one-week cruises to the Bahamas. Okay. For the top people. Okay. I'm sitting in the meeting, and the announcement came out. So who made that decision? I want a trip. Nobody offered me a trip. So I mean, some of these things, I don't know. I'm more hands off than I'm hands on. But anyway, they're happy, so I'm happy. Okay. We don't rely on traditional referral patterns. We know we put word out. We participate in a lot of community activities. We go to a lot of churches. Every pastor has an anniversary. We're there. If they have a big event, community event, we're there. We try to participate. We have a regular radio show every week. I'm trying to get a podcast going, and we have a regular article in the regular community newspaper, and so we do a lot of stuff to keep our name and image out there. So, what's wrong? And this is, I think that's our receptionist. Many underserved patients have no clue what hospice is, so because no one tells them. So I call it systemic racism, Okay, and about systemic racism, I don't. It sounds bad. I don't mean anybody's doing it intentionally, but it's kind of like you just you don't pay attention to it, and so many don't understand how hospitals save their money because no one tells them, and many simply do not trust health care providers. Again, no, you got a lingering of distrust from other bad things. Okay, um, our secret, we're not in it to make a profit. Of course, you got to make a profit because we still got to make payroll. But we ourselves, I think last year I think we paid ourselves $6,000 bonus, but that's nothing. You know, for the $400 a month, I saw all together I earned maybe 10,000 last year. We pay our CNAs more than that. Our goal is to increase access to hospice care for minorities and underserved people. We want as many minority professionals we want to increase diversity at the top of the industry as much as we possibly can. Okay. Like I said, our marketing effort is more educational. We have a radio program. We have a newspaper campaign. We gave each of our employees $100 cash and said, go spend this money with whatever small business you want to spend it on. Just make sure you take a picture with the owners and let them know that it came from us to try to help promote small business. I'm telling you, that came to about $5,000. You cannot imagine how much publicity we got from that. Just that, it's amazing. Okay, and as I say, we continue to sponsor a lot of events. We partner with a couple of medical schools. We got volunteers from some of the students in medicine school who come out and volunteer with us on a regular, ongoing basis. We've got some relationship with some of the other regular schools as well. We make our presence known. We pay our. Oh, I already told you all that. And I said, profit. What's that? I don't know. And of course, that's a self-portrait. So I'll be happy to answer any questions that you may have.
Well, I definitely I got a couple of questions from when I asked on our social media today, kind of from students, and one of the questions was, what does a kind of a typical day look like for you as a hospital administrator and working in hospice care? What does the day-to-day kind of look like you? Let's kind of maybe go back to the first one that you opened.
Well, I was still the CEO of a hospital when I opened the first one. So, but being an administrator is the same regardless whether you run a hospital or a hospice. Okay, the challenges are almost identical. Okay, it's all about people, and healthcare is people. Every day you go in as an administrator, there's two things you worry about. You worry about, okay, what's the money looking like? You check with finance. Do we have enough money in the bank to make payroll? And then the other thing is that there's always somebody that's got a problem. Okay, I didn't get my check. Y'all underpaid me. We had a nurse that her car broke down, a hospice, and we rented a car for that woman for 2 weeks. Okay, she was with us about another 3 or 4 months, and then all of a sudden she decided to quit. And I said, we spent all that money trying to help this lady, and she quit on it. She changed her mind later and wanted to come back, but we said, no, we're not going to do it. So as an administrator, it's the same. Whether it don't make a difference whether the business is. And when I was running hospitals, I had 5,000, 6,000 people and a $40 million budget, or a hospice that's got a $3 million budget. It still doesn't make any difference. The problems are almost identical. As an administrator, it doesn't make any difference. It's people. They drive you crazy.
It's the people that drive the business too, right?
Yeah, it's the people that drive the business. I don't know what to tell you. It's true.
So you had mentioned that you kind of wanted to be a cartoonist, and you had a scholarship kind of to do that, and then you got cold feet, and then you got to MSU, and then you kind of thought the MT program. Why did you think that would be kind of a good avenue for you?
Well, it's a good question. Back then, I remember that I picked going into the lab because I wanted something that was steady. I wanted a skill that I know would always be in demand. Okay, and I knew a lab, in the lab would do that, particularly if you get certified, ASCP certified. And I was right in that respect. And I would have been just as happy making a good living as a registered med tech in a hospital. Even if I stayed in 20, 30 years, I would have been just as happy. But I was ambitious and I wanted to make a difference in healthcare. And I saw administration as a means to control power and control people and control resources and money. Okay. And that's when I changed my focus to hospital administration. But even after I got my degree in hospital administration, I kept my certification up in the lab for 2 years because I said, in case somebody says, hey, we're going to bounce him out of here, I wanted to be able to go back to the lab if I had to. So I only gave it up after about 6 years. Okay. But I kept my fees up and my license and every certification legit for at least 6 years. Then once I decided, okay, I can make it as administration, then I gave up worrying about the lab. I can still read urines if I have to. Don't ask me to do nothing else though.
Anyone have any questions? Any students?
Don't be shy.
Was actually gonna ask, sorry, my video's glitching. Have you used like some of the skills that you gained as kind of like when you got your clinical certification and stuff? Have you been able to still use some of the skills kind of like in administration, kind of like helping you guide some of your decisions, maybe?
Yes, yeah, because as an administrator, you get isolated from the clinical side. Because you're in an office that's away from it, and you're so inundated with worrying about finances and personnel problems that you don't get to see the real plight of the patients and the problems that you encounter when you're in a clinical setting. So I try to remind myself to go out and do rounds in the facility. As administrator, I always did rounds, and I walk around and talk to the clinical people, and you'll be surprised how many people come up and tell you things. Particularly, stand-up meetings are better than sit-down meetings because people talk faster and they talk more to the point than you do in a sit-down meeting. Okay. Secondly, if you think I know administrators say, well, I have an open door policy. Nobody deliberately comes to administration. Okay, they look upon that and say bad things happen to you when you go in there. So you could take the door off the hinges. They're not coming. You have to go out and about. And I usually made rounds during the week, 24/7. Okay, and I did them not predictably. I tried to be at random so that they don't know when I'm going to do it. If I've been out at a banquet or something on a Saturday night, I may swing through the hospital at 1 o'clock in the morning. You're surprised what that midnight crew does, man. They are there. You hit that front door. By the time you get to the 5th floor, everybody knows you're in the building because they are a really, really unique crew. They are tight, but they also but next week everybody knows that fool showed up at 1 o'clock on a Saturday night. So you can't be predictable. You got to walk around and do it, in the evening shift because it's 24/7 and they like to feel like, you didn't forget about them. And like I say, it also makes you not get too insensitive to the fact that the clinical people have problems. Because most of the arguments that I had were with the clinical management over staffing and getting to know, I need this new piece of equipment or I need more people, and you have to argue with them, sir. Gonna put more people on the payroll. I'm already having trouble paying the ones I got. But they keep saying if you don't put it, how nurses talk. If you don't put them on there, the quality of care, we're gonna hurt somebody. You don't want to do that. So you give it to them, but you can't have people sitting around. They act like they're super busy, but they're not. Okay, because during holidays, volume always drops. I don't care what business you run because doctors and everybody likes to take off. Nobody goes to see a doctor or get sick during Christmas and New Year's, or on a 4th of July holiday. Who wants to be sitting up in the hospital and everybody else is out looking at fireworks and having barbecue? Ain't happening. Okay, so that means all them people you got on staff doing nothing because the census is down. Okay. still, this past December, we had 75 patients going into Christmas, and all of a sudden, 10 or 12 of them died. I mean, boom! I said, "What in the world?" They were dying just boom, 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 boom. And by the time we hit January, we were down to 60. Okay, now I knew this would happen. It always happens at this time. So I didn't worry about it because I knew we would bounce back. But I still got people on payroll and they still wanted their checks. So we didn't say anything. We just said, okay, that's the way it is. That help you? You don't lose. You got to keep your, and plus you can still talk clinically to other people too. It's terrible if the administrator can come up to you and he doesn't know what a hematoma is or a bed sore is,
Thinking back to when you were a student at MSU, do you have a class that you remember that kind of sticks out for you, that you remember fondly?
Well, I had two of them. One was physiology class, and I think one of the test questions was to draw some kind of digestive system thing, and only 3 of us passed the test. Okay, and I was one of them. But mine was, I won't tell you, it was strictly by accident. I didn't have a clue. I just drew something. So it was clearly, I said, he said, you did real good. And I said, I don't even know what the heck I was drawing, And then the other one was a biology class, and where you had to go around to 8 or 9, 10 microscopes and look down the scope and identify. You probably have had this, where you had to identify the bacteria or whatever it is or what the gram stain was on the slide and all that kind of stuff. And I thought I was pretty good, but there was one slide that didn't have nothing. And I said, what the heck is going on? I looked and looked and looked. And I wasn't the only one. There were several of us that missed it. You know what it was? It was our darn earthworm. And he had slid off from under the lens, and nobody thought to look down and see if it was a worm. We all were looking down the microscope, looking to see if something was on the slide, and it wasn't. And the instructor just laughed and said, you guys better learn to look down. Don't just look through the scope, look down and see what's on that thing. So I remember those two.
Nice. Any other questions, folks?
Yeah, I would say, because I mean, hospice is quite a heavy topic as well. What kind of do you have any advice about kind of grieving or kind of that emotional kind of relationship with a lot of the patients?
Well, the only thing I personally have done of late is, because I'm a veteran, is on Veterans Day, the team will ask me to go out and see any patients that are veteran. And we buy gifts and symbols. One time we had a little pin, and I pinned it on this guy, and I had to wear some veteran garbs, and thank him for his service and so forth. So, but by and large, I don't go out to see a patient. Now, my partner, the bishop, he goes out and sees patients and talks to the family and prays with them and all that type of thing. And then, so he does a lot. We got 3 or 4 pastors now, and then that's what they do. The nurses, I think nurses do what nurses do. They just, in addition to treating and worrying about falls and feedings and making sure any bruises or bed sores and things like that they have, they do their nursing thing. I think they're tuned in to do that. I think in terms of grieving, we try to do a lot. We have a grief kit we give out to families, and obviously we have to stay with them because the regulations require that we stay in touch with families for at least 12 months. So they don't just die and we just leave them alone. We stay in touch with the families and try to do things with them periodically just to make sure. So we don't turn them loose. That answer your question?
Yes.
But again, I don't do it anymore. I used to do it way back, but not anymore. Any other questions? So Anyway, I hope this was somewhat helpful to you. Just keep an open mind, be flexible,
Absolutely.
and yeah. And I would also tell you, I've created 4 panel exhibits on Black medical history. They're 3 feet wide, 6 feet tall, and one was on who was first. The other one was Black military legends, and then the other one was on Black medical schools, and I can't think of what the 4th one was. But anyway, I've sent them out around the country. I wasn't doing it for money, but they paid for themselves. They, like right now, I've got it because of COVID, everything stopped. But they've been to a lot of health systems, churches, a few museums, and right now I've got a digital one. I've got 35 videos that I created that are at Children's Hospital in Omaha right now. Okay, I've had it up at University of Pittsburgh, McGee Hospital. I've had an exhibit in the Louisville Historical Museum, Detroit Historical Museum, several other hospitals and churches around the country. And I've written 8 or 9 books, mostly children's books. I've got 2 books that I've written related to hospice called Tying Up Loose Ends, which tells people how to put your personal affairs in order. And then I've got children's books that went along with the exhibits. Okay. And I've authored maybe 75 articles. My first 2 I did as a student. I tell you that so to make you think. All those papers you write, convert them over to an article. Send them off. There's at least 700-800 places that love to get articles. You can publish and you send them and look good on your resume if you publish. And if you want to become an expert in something, publish on the same topic each time. And eventually people will say, oh, we need to get somebody like that to come speak at our conference. Okay. So, and of course you should join the associations. You should, the MedTech Association, which I belonged to for a long time. And, but my main one has been the Black Administrators Association, National Association of Health Service Executives, and ACHE, American College of Healthcare Executives. I've belonged to both of those for over 50 years. Okay, I joined them pretty much the same time. And I try to go to all their conferences, or if not, I stay in touch. And it's been very beneficial. You should do that. That's how you make your reputation. You cement your image. If you want to be in demand, that's what you got to do, that extra step. Don't do like everybody else. Then you get paid like everybody else. You want to get paid different, you got to do something different. Okay, and just because you're a student doesn't mean that you don't have something valuable to say. Besides, the 2 articles I first published, they didn't know I was a student. They just published the article. They didn't ask. So what the heck? You don't ask. So I got over it, and I've written a lot of articles since then. And if you wonder if I ever go to sleep, yes, I go to sleep sometimes.
Sometimes.
Sometimes. But I get up with a purpose every day. I mean, I gotta do something every day. That's always my goal.
Why is that?
I don't know. It just inside me driving. I will tell you this: the older you get, and I've got colleagues who have retired and they want to still be doing something because they've been busy all their lives, and they don't have anything to do, and then eventually they just waste away. I think staying busy keeps you alive. Okay. I've played racquetball 3 times a week when I was administrator. I always scheduled it either early morning or early in the evening, and for that reason, I don't take any medicine. I don't have any high blood pressure. I don't have any diabetes. I don't have anything. I just had cataract surgery on one eye, but other than that, that's it. I play pickleball now. Racquetball too fast for me now. I gave up golf. So I play pickleball 3 times a week right now. Okay. At my age. And so that's if you don't have health, you got nothing. I don't care how much money you make. Okay. So remember that you must stay active. Okay. You got to keep your health. And so for that reason, my wife, she takes a lot of medicine. Sometimes I can't get her to exercise, but I don't take any. And so that having purpose keeps me alive and focused. Okay. That's why I stay busy. Because when you get older, you got to have something to do. Hey, I appreciate you guys taking the time to come listen to me dribble on here. So
That's all. We
Yeah.
appreciate your time, Dr. Lee. Really, really
Yeah.
do. Thank you for taking the time out, just speaking with our group here, and hopefully we can stay in touch a little bit more.
all right. Thank you all. I appreciate it. Feel free to
Yep.
call me or reach out if you need anything.